Dr. Shira Kresh. I'm at Kresge Eye Institute in Michigan. And today I'm going to be talking about the drop debate, patient considerations, and conundrums. I just want to give a couple of thank yous. Number one, to Justin Schweitzer and the entire Eyes on Eye Care, Eyes on Glaucoma team. It's been a real pleasure working with everybody, and specifically Eleanor, Julia, and Sam, who have been really helpful in terms of getting this presentation up and running. So thank you so much for that. I have a couple financial disclosures for this talk. Getting started. When Justin asked me to talk about this specific area, the drop debate, talking about which drops are for which patients, I was really excited to put this together because there are so many types of glaucoma patients and so many choices of drugs. But oftentimes we hear that people have like a cookie cutter approach, like prostaglandin analog goes first. If that doesn't work, then you go to a combination or something like that. And what I want to really bring out today is that it's not that simple, especially if you're treating a lot of glaucoma patients. Everybody comes with their own kind of package of medical and ocular histories and different kinds of side effects that can affect them in various ways. So I like to say that glaucoma is as much an art as it is in science, as it is a science. But the science is really, really important because a lot of these drugs, as we'll get to, have a lot of possible adverse effects, and some can be systemic and problematic in certain patients. So with that being said, let's move forward. I just want to present a couple of ideas of patients that are just to generate some thought in the audience. So case number one, you have a 30-year-old white female who has ocular hypertension. So pertinent history, she doesn't have glaucoma. She just has a lot of risk factors. She has strong family considerations. So her mom has it, her grandmother has it, let's say. She has a large CD, she has thin packs, and she has hazel eyes. She has no real medical issues. So she's a young, healthy woman who comes into your clinic and has ocular hypertension. Let's say you decide that she needs treatment. What kinds of drops are you going to be thinking of? Because all of a sudden, if you jump to prostaglandin analog, you're putting this 30-year-old woman who doesn't actually have a disease in something that's going to affect the way that she looks for a long, long time. So that's something to consider. Number two, you have a 57-year-old white male with early glaucoma. He has a few medical issues. He has asthma, hypertension, he's a runner, no other medical issues. Now, you should start thinking about which side effects of the drops would not be good for this man. So the one that I hope that at the end of the talk you'll know is timolol would not necessarily be a good option for him, but there are others that could. Number three, you have a 90-year-old African-American female. She has moderate glaucoma. Now, you don't know her life expectancy. She may live another 10, 15 years, but she has low blood pressure, pacemaker, she's allergic to shellfish, no other medical issues. So what kinds of things are you thinking about here? If something that can cause systemic issues might be more problematic. She might be on other medications too that you have to take into consideration. Case number four, you have a 45-year-old Hispanic female with unilateral uveitic glaucoma. And what's interesting about someone like this is that when you're dealing with a unilateral glaucoma, something that is going to affect one eye and not the other in terms of the way that the patient will look has to be something that you either discuss with them if you're going to start them on a drop like that. Because a lot of the drops, even if it's not a prostaglandin analog, as we'll get to, they can cause redness. They can cause like foreign body sensation. You're constantly putting drops in. It's a different kind of thing when you're dealing with one eye. Now, obviously she has uveitis, and I kind of mentioned it already, that also at the end of the talk, we should know that prostaglandin analogs is not a great choice for someone like this. She has no glaucoma suspicion in her right eye, and she does have a glaucoma defect with progression in her left eye. So you want to treat her with something. It's going to be in one eye. Some people like to treat in both eyes while they're treating, but she really doesn't have any glaucoma in the right eye at all, or any suspicion of glaucoma. So what do you do? So let's go through a couple of technical jargon. Number one, what is a contraindication? That's a pre-existing condition in which a drug is not safe or effective. Those can be loose or a hard stop. So if somebody has asthma, there are certain drugs that are contraindicated in those patients. Number two, what's a side effect? A side effect is an undesirable effect of a drug that's predictable by the drug's method of action. So an example of a side effect might be that if you take a prostaglandin analog, then you might get, you should expect to get iris pigmentation. Number three, an adverse event is an undesirable effect of a drug that's not necessarily predictable by the drug's method of action. And that could be dose dependent or not dose dependent. So that could be talking about just an allergic reaction that some people have and some people don't. Okay, so moving on. So when we treat glaucoma as eye doctors, what we have to remember is our treatment goal. So we have to weigh the clinical benefit versus the potential harm. We need to choose the hypotensive agent that has the highest likelihood to reach the target IOP, but with the lowest risk profile for each patient. So we want to prevent blindness. We want to prevent the progression of glaucoma. We want to lower the pressure enough that the patient will not develop worsening of their glaucoma to the point that they have visual impairment. Or if they have visual impairment, that we can lessen the progression of that visual impairment. But the other side of that is that we have to take into account the risks of the drugs that we're treating our patients with. Make sure that their glaucoma risk and lowering the pressure inside the eye is not going to affect them adversely systemically in a way that would not be healthy for them. All right, review on mechanism of action. So aqueous is produced by the non-pigmented epithelium of the ciliary body. It's controlled by several factors, including different enzymes, blood flow, and the kind of analogy that's easy to understand in terms of aqueous is if you're, let's say, blowing up a balloon and you want to stop having the balloon get too big, there's two ways you can do it, right? So if you're holding the end of the balloon and the balloon's really big, you can either stop blowing into it, so decrease the production of air that's going in, or you can kind of open the end of the balloon so that some of the air squeezes out. And that's a way to kind of think about aqueous production and aqueous outflow. That there's two kind of approaches with these drugs in terms of dealing with lowering the IOP, the intraocular pressure. Either we can lower the amount of aqueous that's being produced, right? Or we can enhance the outflow of the aqueous that's being produced. So a lot of the drugs target both mechanisms, some better than others in terms of either one. So let's go through them quickly. So first of all, aqueous, remember, let me use my pointer back here. So aqueous is produced by the non-pigmented cells of the ciliary epithelium, and then it travels through the pupil, gets caught up in the convection currents, and then it drains in the angle. So the iridocorneal angle. And there's two different outflows. There's the trabecular meshwork, the conventional outflow, and then there's the uveoscleral, the non-conventional. So here it is again. So you have the trabecular outflow going through the trabecular meshwork. That's the conventional path. And then you have the uveoscleral path that kind of carries it to the sclera. And then that gets caught up into the venous structures of the eyes and gets drained. Now, something else that we have to talk about is the systemic absorption. So totally different kind of pathway. When you take the drop, how is it getting systemically absorbed? So remember that it goes through the puncta and it gets carried down into the mucosa of the nasal cavity. So it bypasses the first pass or whatever through the liver. So it doesn't get metabolized in the liver. It gets absorbed systemically easily through all those, through the highly vascularized mucosa of the nasal cavity. So that's when we talk about systemic effects, that's where we're talking about it being absorbed. Okay, so now let's get into the meat of this. So we have the different categories of topical medications. We have beta blockers, we have alpha agonists, we have prostaglandins, and I included the nitric oxide component into there, which is Vyzulta, because it's not really its own category. And then you have carbonic anhydrase inhibitors, rho kinase inhibitors, and the miotics or cholinergic agents. So let's go through them one by one. So remember, they're each going to be affecting outflow or aqueous humor production in various capacities. Let's talk about beta blockers. Beta blockers used to be like the first line, right, of medication because it gets a big bang for its buck. You put it in the eye and it can lower pressure by like 20 to 30%. It can be dosed once a day, it could be dosed twice a day, but the problem with them is that they have all these possible systemic complications, these systemic side effects. So first of all, contraindications if somebody has congestive heart failure, bradycardia, AV block, or pulmonary issues, asthma and COPD, hard stop in your mind, beta blocker would not be a good first choice for these kinds of patients. And then also special hobbies. If people like to run, if they're particularly athletic, beta blockers can lower the heart rate. And so these patients can have issues with that. Okay, so let's talk about some of their side effects. So let's say you decide to go ahead and use a beta blocker. So you can expect burning, stinging, photophobia, conjunctivitis, a lot of different like topical issues, but you can expect that with a lot of eye drops, nothing that's really super specific to the beta blocker. And systemically, the biggest one that should be on your list is the decreased heart rate. But then also bronchospasm, hypotension, depression, decreased libido, impotence, alterations lipid profile. I mean, patients will come in, and we've all had patients like this that read the back of, that read the fine print when they get the drugs, and they're like, what am I taking here? And you have to think about who you're prescribing these for and whether or not these are good, this is a good idea for them. So these are the beta blockers that we talk about: timolol, levobunolol, cardiolol, and betaxolol. I want to take a quick second to acknowledge the Department of Ophthalmology in Iowa. They have a really fantastic resource online that's called iRounds, EYE Rounds. And I got a lot of these charts from there. But they have a really great, a lot of great resources in terms of glaucoma understanding. So anyway, this is where the art comes into glaucoma prescribing as well, in terms of deciding which beta blocker do you use and which percentage and which dosing do you use. So there's a lot of leeway that you have. You can start a patient on 0.25, you can start a patient on 0.5%, you can start with QAM, you can start with twice a day. Something to remember about beta blockers is that they don't really work at night. So it's best prescribed in the morning. They also have a diminished response if a patient's already on an oral beta blocker. And then betaxolol is a really good thing to have up your sleeve for patients who do have heart and asthma issues or pulmonary issues. That is a more selective, that's beta 1 selective, so it doesn't affect the beta 2 receptors, which is more pulmonary. That those are good options specifically, for pulmonary issues. Okay, so let's look at an example. This is a 66-year-old female with proliferative diabetic retinopathy and primary open-angle glaucoma. Vision is not great, 20/80, 20/50. IOP is 20 on the drops, and she's currently taking Cosopt, which is the combination dorzolamide timolol. She's taking brimonidine and Ropressa. Medical history is asthma, diabetes, hypertension, history of stroke, and high cholesterol. She tells you that she's getting a cough at night after she's taking her drops. So this is something you have to think about. Which one is most likely to be causing this issue? The first one on your list should be Cosopt. And so you may want to think about breaking that down into dorzolamide, but the thing is her IOP is also borderline. It's 20, so you don't know, we don't have on here what her target is, but if that's an issue, then maybe putting her on dorzolamide 2 or 3 times a day is not going to be enough. You may have to think about what else you can put her on. Either adding a PGA or adding a sending her for SLT or something. But those are different considerations. Once you're taking her off a drop, what else could you do for her? Usually when patients come in and they have a bunch of medications that they're on and they're not on a prostaglandin analog, there's usually a reason for it. So if you see that, do a little bit of investigative work to make sure that there's not a real reason why she's not on it. So things to think about with beta blockers is there respiratory or heart disease in this patient? Is the patient high risk for hypoglycemia? Is there depression, anxiety, fatigue, or impotence? Does the patient have thyroid disease or myasthenia gravis? We didn't really touch on that, but that also can be exacerbated on beta blockers, and other considerations in terms of hobbies and things like that. Okay, alpha agonists. So alpha agonists are awesome because we don't really understand how they work so well in terms of lowering the pressure inside the eye. But we know that they target the alpha-2 receptors, so they are selective in that sense. And they decrease the aqueous production and also increase aqueous outflow. There's also this idea, some evidence that supports that they're kind of neuroprotective. So this is the drug that a lot of people like to use in like younger patients who have kind of a lower risk, or someone who is more concerned about their using a prostaglandin analog in terms of what the topical effects are. But you're also dealing with a brimonidine, and we'll get to the side effects in a second. Hard stops for these kinds of patients is orthostatic hypotension, depression, Raynaud's, and then also you have to find out what kind of oral medications the patient's taking. If they're on digoxin, antidepressants, oral beta blockers, those can have bad side effects if they're both administered. Okay, so side effects. Brimonidine is notorious for side effects. So Really, it started with aproclonidine, and patients, around 40% of patients had a true allergy to aproclonidine. It's less so with bromonidine, but it's still about 20% of patients that can't tolerate long-term therapy with bromonidine. It doesn't mean that you can't try it and try to keep patients on it, especially if it's a good idea for them, but you can also expect that they're going to have um, some uncomfortable topical side effects. Um, Something also to know is that there is a hard stop in children. So if you're in a clinic or practice that you treat kids, 3 to 4 year olds have an absolute contraindication against alpha agonists because it can cross the blood brain barrier. So that can cause really terrible side effects, and you absolutely cannot prescribe it in those patients. But in terms of the local side effects, we've seen it. Now, the conjunctival blanching is also interesting. Like, you might hear your patients, you think about alpha agonists as causing that redness and uncomfortable and conjunctivitis and all that, but it is a vasoconstrictor. So right after you take it, patients can say, oh yeah, no, my eyes look a little whiter right afterwards, but then they get red, and that's normal because of that vasoconstriction property. So systemically, you can get headache, drowsiness, fatigue, lower high blood pressure, slowing of heart rate, and dry mouth. And then interactions, they can also interact with blood pressure medications, digoxin, beta blockers, and antidepressants. We kind of touched on that already. So I think I have yeah, I do. Let me just go back for a second. So these are the 2 drops. Obviously, bromonidine is the one that we all typically use. Aproclonidine is used for certain circumstances, usually pre or post-surgical or whatever. But the ones that we talk about is bromonidine. And again, there is that sense of the art coming into this of how exactly you prescribe it, whether it's 0.1%, 0.2%, BAD, TAD, and then there are preservative-free options. So this is a fascinating patient that came into the clinic for a second opinion on his glaucoma. He's 57 years old, primary open angle glaucoma. His vision was excellent. He had a pressure of 15, and his current medications were bromonidine and latanoprost. He went to go take his visual field, and he fainted while he was taking the field. So obviously we took care of that in terms of getting in touch with his doctor. So it turns out that his internist is his wife, and she has been treating his glaucoma. So he didn't have an eye doctor, but she put him on these medications. Now, he has low blood pressure. So he said that since he's been on this bromonidine, it was only after like real history taking that he realized that he hasn't really been feeling great, and that it takes him a while to like stand up and like feel comfortable. But we stopped the bromonidine and started him on other drops, and he did much better. So these are real issues that you have to think about with your patients. So be suspicious. When you're dealing with a patient who has a lot of side effects or is on a lot of different medications, remember that bromonidine is notorious for causing a lot of things, except for one specific one that I'll get to in a minute with the carbonic anhydrase inhibitors. So issues to consider with alpha agonists: is the child under 3 to 4 years old? Is the patient hypersensitive? So what I mean by that is, if you have one of those patients who's like has very dry eye, is uncomfortable with a lot of different things, like is very sensitive with her eyes or his eyes, that wouldn't be the best patient to try this on, because they're probably going to have a hypersensitivity to it. Or not be okay with having some of the side effects with the bromonidine. Does the patient have a low blood pressure? And then other types of considerations. Okay, so let's talk about prostaglandin analogs. There's a couple of reasons, but the main reason why we all really enjoy using these drugs is because we don't have to think about the systemic contraindications, because there are none. It doesn't matter if your patient has high blood pressure. It doesn't matter if your patient has asthma. However, the topical side effects are pretty significant, as we'll get to. The other reason why we love using prostaglandin analogs is because it's dosed once at night, once a day, and it decreases pressure from 25 to 33% in the different types of formularies that it has. So you get a really big bang for its buck of using it just once at night. Something to remember is that they should not be dosed more than once a day. It's not like, oh, well, once a day is good, twice a day is better. Actually, if you go back and look at the studies, prostaglandin analogs decrease in effectivity by using it twice a day. So it's not a good idea to dose it twice. Sometimes patients come in and say that they were told, oh, maybe throw in another drop, which would not be the right thing to say. in terms of its side effects. So these are pretty significant, where the iris pigmentation is a real thing. And it's not just that it happens in light irids, right? You have patients who are hazel, and that's what we think about by starting them on these drops. Their hazel eyes will become darker. And that's true in about 33% of patients over the course of 5 years. Those patients have been shown to have darkening of their iris. However, iris pigmentation can happen in anybody. Even with dark irises, it can become darker. So that's something to be to consider when you're talking about prescribing this medication. Eyelid darkening. So the eyelids do become darker, and you want to tell patients to kind of wipe off blot right after they put the drops in to try to decrease that contact time. And then the periorbital fat atrophy. These patients, after taking these drops for a long time, their eyes can kind of look sunken in. And we've all seen those kinds of patients, but recognize that you're doing that to the patient by prescribing this medication. Not that we shouldn't prescribe the medication, but something to consider that you are changing their appearance. Punctate keratitis, burning and stinging, those are not really specific to the PGA, maybe just in terms of the preservative included. And then systemically, they've also been shown to have headache, hypertension in the literature. Now, I also lumped together nitric oxide in here because of the Vyzulta. So Vyzulta essentially took latanoprost and combined it with this new formula, latanoprostene bunad. Now, there's no additional side effects that we know of so far, at least of what I've read and studied from nitric oxide. So it's just the same contraindications, the same side effects as a regular PGA would also be true for Vyzulta. So these are the different prostaglandin analogs. Now, there is no art in terms of how you prescribe these. You prescribe them once at night, except, well, I changed my mind. So the reason why they're prescribed once at night is because they have hyperemia effects, right? So you can get a really red eye from taking the drops. So by taking it at night, you can kind of dissipate some of that redness by the time you wake up. And then over the course of a few months, that redness also can kind of dissipate. But there are patients who must take it in the morning for whatever reason, in terms of their job schedules, or that's just when they're going to remember. And if that's the case, as long as they take it at the same time every day, they can also be very effective. So as long as you can educate them, pick a time and take it, with every night maybe being the best time to do it. But if they can't do it, at least it should be the same time every day. Now, there are preservative-free options of this too, and we'll talk about those a little bit later in a preservative-free section. So this was taken from that iRounds resource. This shows a patient who was treated unilaterally with the prostaglandin analog. I mean, and you can tell right away which eye was treated, right? So you can see this sunken appearance from the periorbital fat atrophy. You can see the very long eyelashes. You can see a little bit of tinge, darkening to the appearance of the eyelid. So, and then the other eye is what the eye should look like before it was prescribed the prostaglandin analog. So these are the kinds of appearances that you would expect by treating patients with prostaglandin analogs. So here's a patient with a 43-year-old female, unilateral uveitic glaucoma. So this is your classic patient that you would not prescribe a prostaglandin analog on 2 accounts, right? So if I asked for a show of hands in a non-virtual setting, which drug should you not prescribe in this patient, as your first line would be a PGA. Number 1, because it's unilateral. Number 2, because of uveitis. Now, what is this deal with inflammation? So going back and thinking about the mechanism of action of a prostaglandin analog, it's derived from arachidonic acid, okay? So it's a pro-inflammatory modulator. So there are, depending on where it's being used in the body, it actually can increase inflammation. And in the eye, if it's used in the eye, it can exacerbate uveitis, it can bring on CME, it can kind of encourage inflammation. So it's not an absolute contraindication in some of these patients, but it's not one that you would prescribe readily from the beginning. Okay, so issues to consider. Does the patient have active inflammation or prone to inflammation? Is this for unilateral use? Does the patient have hazel or light colored eyes? I think that we talked about this one a bunch, so we kind of don't need to review any of that. contraindications for, okay, so carbonic anhydrase inhibitors. So this is also another important category of drops. Number one is a standalone, and number two, because of the combination possibility. So it's in two different combination drugs, and it's actually used fairly commonly without, there's not usually a real strong understanding in terms of its method of action and all that stuff. So let's go through it a little bit. First of all, this is a direct antagonist to the ciliary epithelial carbonic anhydrase, which is the enzyme that's important for producing aqueous humor. So if you think about it, it's targeting the production of the aqueous humor. Now, something crazy to understand is that actually more than 90% of this enzyme has to be inhibited in order to lower the IOP. Just think about that for a second. That just goes to show how potent a carbonic anhydrase inhibitor is. Now, the systemic ones, the oral ones, are very, very potent, and they can decrease IOP in the 30 to 50% range. But as we know, and I'll go through a little bit, their systemic side effects can be pretty significant. So you really have to know what you're doing and be involved with a medical team if you're going to be prescribing it, like acetazolamide, methazolamide, those different formularies. But in terms of the dorzolamide, you get a 15 to 20% reduction by using it in the eye, which is also pretty significant from reducing this enzyme. In terms of side effects, so you get topical, so burning, punctate keratitis, and then you can get an allergy to it. Something that's kind of like a fun fact, if you work in academia or if you have students, something that a lot of preceptors or whatever will like to say after a patient will come back and after a student will come in after using some Brinza on a patient, the patient's complaining of burning specifically when dorzolamide is involved. Usually dorzolamide is the culprit. And the reason for this is because the pH of dorzolamide is pretty low. It's like 5.5, 5.9. So it can cause that burning. But people like to think of brimonidine as causing all these side effects, which we talked about before. But if you know that little fun fact about the acidity, then you know that it's actually the dorzolamide that's likely to be causing the burning. And then the other things can be associated with the preservatives involved. So systemically, a lot of people know that you can get that bitter taste with taking it, then headache, nausea, asthenia, kidney stones, depression, fatigue. Obviously, those are really dealing with the oral carbonic anhydrase inhibitors more so than the topical. Now, another component is that patients with an a corneal endothelial issue, like Fuchs, do not do well with dorzolamide, because it actually can affect the health of the cornea in those patients. So that would not be a good idea. And then thinking about the systemic use, you have to understand the patient's entire medical history in terms of hepatic and renal issues, and then other considerations that you might want to think about. So there is a lot of kind of leeway in terms of how you use the drops, dorzolamide, brinzolamide. And then in terms of the combination drugs, we'll get to in a different slide, and they have 2%, 1%, and dose BID or TID, and then you have two of the systemic options listed below as well. So that's only for docs who are able to prescribe orals, or if you work together with an ophthalmologist and you want to send a patient to go get an oral prescription from an ophthalmologist, just knowing those kinds of things is important. Okay, so Rhopressa kind of made history when it comes to glaucoma drugs, because it was the first new glaucoma drug that we'd had in several years. And similar to the prostaglandin analog, there's no contraindications that would preclude you from using the Rhopressa in your patients. So that's a really big deal. Again, because you don't have to worry about the high blood pressure or the low blood pressure or the asthma or pulmonary other cardiac issues. It's a safe drug. But similar to a lot of the other drugs, it also has its fair share of side effects. So the topical side effects of Rhopressa include conjunctival hyperemia, and which happened in about 53% of patients. And then the others, including corneal verticillata, installation site pain, conjunctival hemorrhage. So what I would say, because I used Ropressa a bunch, is that the corneal verticillata is a real thing. And my patient base, it happens more than 20%. So this is something that I actually expect to see in a lot of the patients that I prescribe Ropressa. Corneal verticillata is like that whorl keratopathy. It's not supposed to affect vision. It hasn't affected vision in my patients, but it's something that does happen, that the other drugs do not cause. And then in terms of conjunctival hemorrhage, that's also that happens also more on the frequent side, where patients can come in with a subconjunctival hemorrhage or little conjunctival hemorrhages. But the hyperemia is the big one, and that's what you want to talk about with your patients initially. Like, hey, you're going to take this drug is great because it doesn't. It's use it once a day. It can also decrease the pressure by about 35%. Sorry, it improves the outflow of the trabecular meshwork by about 35%, and it also works on decreasing the episcleral venous pressure by about 10%, and it has a nice reduction in terms of IOP, also dosed once a day. And it's a similar kind of theory of when, if you dose it at night, then you hope for the hyperemia to kind of dissipate a little bit in the morning. I will also say that the redness does tend to dissipate over time, but it never really fully goes away, at least not in my experience. So you can expect that these patients will tend to have a more red tinged eye if they're on this chronically. So just things to talk about with your patients. And systemically, it's really great that they don't really have side effects. So this was a patient that I saw, 52-year-old white male, glaucoma suspect, artist with blue eyes. Best corrected vision is 20/20. He had a funky looking optic nerve with an OCT that looked glaucomatous, but the visual field didn't really go along with it. So I sent him for a neuro ophthalmic exam, and he was found to have had a history of a stroke. So he had a stroke, and then the possibility of having glaucoma on top of that. It was unclear whether he actually had true glaucoma or whether the defects that he had in his nerve were just because of from his stroke. So we called him a glaucoma suspect, but I was treating him for the glaucoma because his optic nerve was damaged. So with this patient, he was an artist and he cared about his eye color. Now, technically, blue eyes is not the same issue as hazel eyes, but it's still something to discuss with patients because it's possible that their eyes will look darker afterwards. So we did not go with starting him on a latanoprost. We started with Ropressa, and he came back and he was like, he said his family was wondering if he was on drugs, like he had a really red eye from it. But he wanted to stick with it for a month or two. It did dissipate a little bit. We ended up changing him to Rocklatan in the end to get his pressure even lower. So he was on a prostaglandin analog and Ropressa. Another option for him, which would have been fine, would have been bromonidine for that neuroprotective effect, and using it twice a day. It's just that he was really, he wanted to just use something once a day. So we were trying to keep him in that realm. Okay, so issues to consider in terms of these patients is can the patient tolerate the hyperemia, and is this for unilateral treatment? Again, also just because you might get that unilateral effect of having a bright red eye in one eye and nothing in the other eye. Okay, so now we're getting into miotics, cholinergic agents. So I love talking about pilocarpine because it's one of those drugs that back in the day, certainly before I graduated, a lot of people use this fairly frequently. And then as the other drugs became more popular, people kind of stopped using them. But in practices that I've worked in, I've used these fairly frequently in patients who really needed it in terms of they've already had surgeries, they were all maxed out on their drugs, and so we used pilocarpine and increased the concentration of them. So the contraindications are asthma and acute iritis. And the side effects and other things to think about in terms of contraindications is, the truth is that retinal detachment probably should have been listed under the contraindication as well, just because topically when it's used, the risk that everybody is aware of when it comes to pilo is, oh, it can cause a retinal detachment. So when you're thinking about who to start these drops on, you have to know the retina history. If you're not sure if something looks a little funky, if you're not sure if it's lattice or if there's a hole there or whatever, Clearing the patient of any retina issues by sending them to a retina specialist is a good idea, because the risk is rare, but it still can occur having a retina issue. So you want to know exactly what's going on with the retina. The other thing to remember is that these drugs are miotics, and they will cause miosis. So they'll make the pupil smaller and they don't dilate well. So you're putting them at risk of having a retinal event, and then you can't check them very well afterwards. So just that's the big one to consider when you're talking about pyelo. But you also have to remember the asthma component and then all these other kinds of things. Now, using these in young patients is not really recommended in terms of their accommodative spasm component. So patients who are still able to accommodate don't do great in pilocarpine, not in terms of the hypotensive effect. It still works nicely, but they are uncomfortable with the side effects. Systemically, it can cause sweating, salivation, urinary frequency, nausea, diarrhea, and then some pulmonary issues, mental status change, variable cardiovascular response. So these are all, you kind of put these all into the consideration box when you are thinking about treating these patients and what the medical history and ocular history is of these individual patients. You can expect about a decrease of 20% for the IOP lowering, and the method of action is actually pretty neat, where it stimulates the ciliary muscle contraction, and that pulls on the sclera, the scleral spur, which leads to an increase in the outflow of the aqueous. So also a little fun fact there. Okay, so cholinergic stimulators, you have the pilocarpine, and then you have the indirect agent, which is the ecothiopate iodide. It's used less, but there are glaucoma specialists that will use these in also certain circumstances. You really want to know what you're doing if you're using the pyelo. And just going back, you can increase the concentration 1%, 2%, 4%, and go all the way to QID dosing, which is the typical dosing for it. But there is some art in terms of that as well. Let me just see for a second. Okay, so I'm almost done with this. I'm going to go through this quick case. So here's a 78-year-old male with severe primary open-angle glaucoma. He's already had a trabeculectomy. So he has a tube and he has a trab, and he's all maxed out in terms of his medications, and he's using pilocarpine. You could consider increasing his pyelo from 1% to 2% to 4% before having him go for, let's say, another procedure, or these are the really complicated patients to handle, but that's where something like pyelo can come into play. Is the patient myopic? So that would be something in terms of considering not to prescribe the pyelo because of the additional risk of having a retina event. Does the patient have lattice? Again, same thing. Is there a history of an RD? And how is the patient's accommodation? And how will a small pupil affect this patient? So you want to think about that too. If they have a dense cataract centrally, they're not going to see that great on this drug. I want to mention, before I get into combination therapy, there's a different kind of approach in using these medications. So some doctors will use a combination drug first, let's say, or they'll put a patient on 2 drugs right away if somebody comes in with a high pressure. My personal approach that I got from my mentors in different realms of practicing is using a slow conservative approach. Remember that glaucoma is a long-term chronic disease that you will be dealing with these patients for a long time. And it's nice to get as much information as possible. So the way that I approach it is start slow and then build up. So if you want to start on a drug just by itself, so that you can see what the side effects are, you can see what the IOP lowering is on that drug alone before starting to think about adding another drop or going into a combination. That is generally, that's a more conservative way of handling it, just because you can kind of try to fizzle out which drugs are causing which side effects. But if you know that you started them separately on them, then you'll have a better idea for sure about which ones are causing which side effects and how much of an IOP lowering you're getting from dorzolamide versus brimonidine, let's say, before jumping to do Simbrinza. But with that being said, combination therapies are excellent. A quick word about them. So the side effect profiles do not diminish, they're just added. So if you have a dorzolamide and a brimonidine, you're going to get the side effects from both the carbonic anhydrase inhibitors and also the alpha agonists. As an example, it does have easier scheduling. So if, instead of putting a patient on 2 drugs 3 times a day, you can put them in the combination and use it 2 or 3 times a day, which is really nice. But they are potentially a lot more expensive, and usually not a lot, not a little, it's more like a lot. So you want to find out from that patient's medical carrier about which drugs are going to be covered so that you are cognizant of that. These are the different combination medications that are available. The only one I believe that's not on here is Rocklatan, which is Repressa and latanoprost. But these are all great options. They're all dosed twice a day, and they do tend to be a bit more expensive than getting the drops individually, but the dosing you can't beat in terms of dividing up the drugs. Now, sometimes you will get an additional couple millimeters of mercury lowering of eye pressure if you do have the separate drugs versus the combination, but usually they're pretty good. Okay, cost and efficacy. So this is getting into conversation about generic versus branded with the patient. Just because something's expensive does not mean that you should not discuss it with the patient. Offer them the possibility of going, let's say, preservative free versus non-preservative free, and generic versus branded. If they really could benefit from having a branded drug, don't be concerned about having that conversation with the patient. It's for them to decide if it's going to mean less side effects and a better efficacious drug. Now, when to go preservative free? So again, it's more expensive to be preservative free, but have the preserved options failed, and is the eye really beat up? So these drugs are notorious for causing these topical side effects. Dry eye syndrome and glaucoma treatments go hand in hand. So thinking about preservative free, especially with these dry eye patients, having that conversation early on is also helpful. That you can say, we're going to start you on these other drugs that are not preservative free, and there are always options that we could do that are more expensive later on. So it's also kind of building up that preservative free approach, and then knowing about whether the patient's going to be paying out of pocket if the coverage is denied, and having a backup option discussed with the patient. As much communication as possible with the patients when prescribing these medications is so helpful, because they take them every day for many, many years. So they should know what's going on. Now, the back preservative-free option. So most glaucoma drugs have back. There's a couple that don't, like pilocarpine and travoprost, but most of them have the preservative back. And then there are a host of preservative-free options. So these are really come into play with patients who have a lot of drugs that they're taking, can't go into the other types, and are willing to spend a little bit more for a little bit of a better, more comfortable experience with their glaucoma medications. And then we are nearing the end of this. So talking about age for a quick second, remember that age plays a huge factor in terms of treating the glaucoma patient. So when you have a patient who's 90 coming in instead of a patient who's 30, remember that patients are generally going to be on their glaucoma drugs for a long, long time if they're young. And if they're older, they are more likely to progress more rapidly if they present to you at an older age. We know that from SIGITs and the other glaucoma studies that were done. So even though you might be dealing with an older or elderly person, their glaucoma can progress more rapidly. So those are things to consider when talking about which drugs to go on and how much you want to lower that pressure. We didn't really talk about target IOP in this lecture, but obviously that goes hand in hand with this kind of conversation. So which drugs do you avoid in a young person? We kind of talked about that. Which drugs might you avoid in an elderly person? You want to make sure that you know the medical history of the different patients that you're prescribing for. And then what do you know about adherence? There's tons of studies based on compliance issues in terms of younger and older populations, in terms of who is more likely to take your drugs. So considering the population that you work with is definitely important in terms of prescribing different medication dosing. So let's get back to the cases. The 30-year-old white female with ocular hypertension. You might want to start her on like a bromonidine, although obviously there's a lot of different options, and we can talk about this more in the Q&A. You have a 57-year-old white male with early POAG. There's a bunch of different options, but the idea is you want to avoid a timolol or beta blocker. A 90-year-old, in general, in an elderly patient, you want to avoid the systemic ones, the ones that has the a propensity for systemic side effects. So you would not put this patient, let's say if they have low blood pressure, on bromonidine, but you can't put them on the dorzolamide either because they're allergic to sulfa. And then you have a 45-year-old with a unilateral uveitic glaucoma, you would just want to avoid prostaglandin and analog and think about the other ones that aren't necessarily going to have such strong side effects topically. So summary, we talked about the medication categories, we talked about some absolute no's, and we talked about some other considerations. Please make sure, I would love to hear your questions in the Q&A, and I hope that that we learned something together here. These are my references, and thank you so much for listening.
Dr. Kresch, unbelievable lecture. Thanks so much for being here at Eyes on Glaucoma. And I have a few questions for you. As I sat here and listened through all the different glaucoma drop options, it reminds me that we have a lot of tools in the toolbox from a drop standpoint. You did such a wonderful job and a beautiful job of kind of going through our considerations in regards to that. And I think one thing I wanted to ask you about is, do you consider when you're prescribing a drop, because I think of glaucoma like a marathon, it's not a short disease, it's something we're managing for an extended period of time. How often do you take in ocular surface disease or quality of life issues when you're making that decision on what type of drop you're going to prescribe?
Wow, that's such a good question. So first of all, let me just say thank you again for having me. This is a really great experience. It's such a really fantastic program to be a part of. In terms of getting back to your question, so dry eye and glaucoma obviously is going to be something that goes hand in hand. It's definitely something that I consider with every single glaucoma patient, and it's a conversation that I have with my glaucoma patients before I start them on any treatments, because they have to know what the long-term game is here, that they're going to be on these drops. They are going to cause side effects. Most of them will cause a couple of side effects, but at the very least, they will probably experience some sort of dry eye, just so that they understand that that's like a side effect of the drop. But it's still important to take the drops because it's so important to preserve their vision as best we can. And these are the best ways that we can do it. With that being said, I don't usually jump into a preservative-free option because they're much more expensive, and it's already a discussion point in the beginning about having the patient even just starting to take the drop. So my general approach is very conservative. So we start slow and we build up. And the generic versus branded is also a tough one. And unfortunately, it usually comes down to cost. It usually depends on how good their insurance is and what we can get approved and what their realistic chances of them even picking up the drops and using them if they're super expensive. So generally, patients are going to be more comfortable taking their drops more frequently and being compliant if they are less expensive. And then if they understand their glaucoma process and they understand that this is to preserve sight, then they'll still take it even if they get the dry eye. For patients who are able to afford it and go with a branded option, it's sometimes it can be better in terms of the kinds of preservatives are there, but not even always. And then you have to go into the preservative free. So it's definitely a discussion point. And I wouldn't say that it all happens at the first visit. The first visit is kind of like, we're going to have this experience of dry eye, and it's just something that we do hand in hand. And we do that with also conservative approach. So yeah, that was a long-winded answer, but I hope that I covered some of it.
Excellent answer. We appreciate you sharing your expertise. A brilliant answer. So thank you. The next question I have, we have about 3-4 minutes. I want to ask you this. You brought up some great points around the different medications that we utilize. I think you and I both agree that our first go-to medication is typically prostaglandin. We may talk about some other options, SLT, whatever it may be, but from a medication standpoint, we're going with the prostaglandin because they're tried and true. They work very well. They're typically well tolerated, but many of our patients need a second medication. And something came up, when we were all discussing and chatting as well, that beta blockers, and you mentioned this, don't work really well at night. And so we all prescribe them just once a day in the morning. So the question I have for you is it time that we make that consideration where that prostaglandin is number one, but number two, we should think about maybe an adjunct agent that is better controlling through a 24-hour period? Or do we still kind of follow that protocol where the next add-on is typically something like maybe a beta blocker or a CAI? I'd just love to hear your thoughts on that over the last couple of minutes here.
Yeah, so also that is such a complex question and a really good question, because historically timolol was a go-to, right? Like timolol and pilocarpine are what physicians used to be treating their glaucoma patients with. But I've worked with a lot of different glaucoma specialists, and timolol is still heavily used in busy practices. And I also use it. It's also part of all the combination drops. So, and the complication as well is that all studies are still compared to timolol as a gold standard. So it's definitely seen as something that we're using, that we have a lot of data on. It's almost like if you switch out the Goldman tonometer for something else, you lose all the data before it that consider the Goldman a gold standard, right? So it's like, it's complicating it. Even when something new and exciting comes out, you still have all this other data on these other things. In terms of it not working at night, I think the most important thing is for people, practitioners and patients, to recognize that, so that they do remember to take it in the morning. It's also a discussion point. We like to hand out there's a paper on it. I can send it out, but it's a paper that describes that it doesn't work so well at night, or that you shouldn't be taking beta blockers at night. And we've had patients discuss with their internists if they're on different beta blockers. But that's like an important discussion piece. Whether or not I think that we're going to get rid of it, I don't think so at this point, and I'm not a big enough person to suggest such a thing. But the other component is that also a lot of these studies just show that it's not just timolol that's not working at night, it's anything that is involved with aqueous suppression. So the drop that works the best at night in a bunch of the different studies is the PGA, because it goes through the uveoscleral pathway and it's less about aqueous production. But any aqueous suppressant is actually, those are the ones that don't really work so well in the different studies. So there's like a lot of hype about timolol, but the brimonidine, dorzolamide, there are studies that also say that they don't really work so great at night either. And then there are other studies that counter that. So I think it's definitely a good controversial discussion.
It's great. Yeah. And that's why I wanted to bring it up. And you're exactly right. There are other medications in that group. It's not just timolol. Well, again, I just want to thank you for being part of this meeting, part of being Eyes on Glaucoma, and sharing your expertise with us. Really great lecture, and enjoy the rest of your evening.
Thank you so much. Thanks for having me on here.